Our next speaker is Dr. Eli Diamond from Memorial Sloan Kettering, New York. His abstract is entitled A Multinational Series of 26 Patients with Mixed Histiocytic Neoplasms, highlighting a diverse multinational landscape and superior efficacy of targeted therapies.
Hi again. You'll be done with me soon, I promise. Same disclosures. So when it comes to the mixed diseases, which I think are very interesting, albeit uncommon, the prototype is the mixed LCH ECD entity, which there's this one large series from Julian and the French group, in which the pattern that was observed is that the LCH is generally prior to or concurrent with the ECD, that it's more of an ECD-like clinical phenotype. In that series, the patients were poorly responsive to the conventional treatment given, which is interferon, and that this is essentially an entity that's defined by the BRAF V600E mutation. The patients who had an asynchronous diagnosis did worse. So that's sort of the LCH ECD entity. And then, there's the one series with our group and the French group and others with the mixed ECD Rosai-Dorfman disease, which, in that series was mostly men, and then associated very strongly with the MAP2K1 mutation. And then also, if you sort of look back at the results presented there, not great responses to conventional treatments. And sort of the third sort of collective sort of look at mixed diseases was this systematic literature review from Italy, which sort of classified the mixed diseases into three types: sort of multi-system, what was called therapy-related, which is to say the non-LCH developed in the course of treating the LCH, and then single-system biphenotypic lesions. And in that series of the 105 cases, the only mutation that was described was BRAF. So what we were hoping to do in this multi-center study was to try and characterize a large cohort of patients with mixed disease, see if there's a molecular characterization merited beyond BRAF V600E and MAP2K1, and then outcomes for treatment and whether there's any implications for workup and management. So this is a collaborative study between our group, the Mayo Clinic, UAB, Cook County, and the Israel group. And these were patients with confirmed mixed disease, whether ECD-LCH, ECD Rosai-Dorfman, or RDD-LCH. All of the diagnoses were confirmed by two or more of the pathologists at our participating centers. And then we looked at presenting symptoms, sites of disease, whether the diagnoses were made at the same time, and then what mutations they had, and then response to conventional and targeted therapies fairly analogously to what I just showed last hour with the MAP2K1 series. So thus far, we've described 26 patients, mostly men and mostly mixed ECD-LCH, some ECD Rosai-Dorfman, one patient with an RDD-LCH, which is not very common, and then one patient with all three. And the majority of the patients were sort of diagnosed in an asynchronous fashion. So similar to what has been observed before in the mixed LCH ECD entity, the LCH came first, although not invariably, and then some were diagnosed at the same time. The ECD RDD entity is pretty uncommon, but it was diagnosed mixed most of the time, and then sort of one off each other way. And then the LCH RDD was a biphenotypic lesion, and that was diagnosed at the same time. And sort of a fairly typical distribution of disease, although pretty enriched for neurologic and bone sites. And I'll show the mutations a bit more by each mixed entity, but we found many BRAF mutations, MAP2K1, but also a MAPK3, which is an ERK1 mutation, some RAS, non-V600 BRAF fusion, and RAF1 mutation. So I think a bit more diverse than previously appreciated. Looking at the biopsies, there was 82 biopsies in the 26 patients. And most were, one subtype in the biopsy, although 14 were biphenotypic. Of the biphenotypic ones, 8 were ECD-LCH, and these others, just to, of note, many of the biphenotypic sort of LCH, non-LCH were in the skin. And then they were kind of distributed among the other organs. So apart from sort of the somewhat, modest predominance of skin subcutaneous mixed ECD-LCH, it didn't really adhere to any other organ that this is where you were going to find a biphenotypic lesion. This is where I look awkwardly at my pathologist. This is a sort of histiocytic infiltrate here. You see the CD68 positivity, but you see this demarcation of the CD1A with the LCH infiltrate on the left, which I think corresponds to this upper left side. See, there we go. This is the LCH part, and this is the this is me impersonating a pathologist. And this is the non-LCH element over here. And then likewise, this was one of this unusual Rosai-Dorfman LCH mix. You can see the little imperapolesis here in the Rosai-Dorfman element. This is the LCH element, and you see the very strong demarcation by the CD1A stain. And I believe this was OCT2 conformed to this as well in this case. So to look at the mutations by the entities, just to highlight what I think has not been previously observed, in the ECD-LCH entity, we had 2 MAP2K1 mutations, this ERK1 variant, a BRAF in-frame deletion, and a BRAF fusion. In the ECD-RDD entity, we had a KRAS mutation and the RAF1 mutation, and then a MAP2K2 mutation, which I believe is the second MAP2K2 variant to be described in histiocytic neoplasms. And then looking at the treatments, the outcomes with conventional treatments were, pretty poor. Very few complete responses, and then of the responses to conventional treatments, there was a predominance of relapse, as opposed to targeted treatment, which did substantially better. Just to be sort of clear about, because I noted that there was 5 instances of progression on BRAF MEK therapy. Those were, I would say, not true progression in the way that I described in my last talk. One patient had progression on very, very low dose COBI and then recaptured their response. 2 patients with isolated neurologic progression on very low dose monotherapy. So I think that's more of a de facto progression than progression per se. And then recurrence following discontinuation, which we counted as a progression because that was the case, but not a resistance. And then 1 patient with neurologic progression on a low dose MEK inhibitor. So while there were instances of progression on targeted therapy, if you look at the details, they were not sort of really that notion. This is the swimmer plot, and so what I put as the time 0 is the initiation of targeted treatment. And so what you see to the left is pretty much kind of like a mass of conventional cytotoxic and immunosuppressive agents, which in almost all cases led to progression, and then you see sort of a very nice clean response on the right half with targeted treatments. Just one couple case examples. This is a young man who had essentially lifelong LCH of the skin and nails and multiple systems, who was treated with just a tremendous amount of different chemotherapies, and then had a xanthelasma on our first clinical evaluation. And he happens to have both LCH and a non-LCH both on the face, just within a few inches of each other. You can see the CD1A positivity difference between the two. And this disease had a BRAF in-frame deletion, and has had a very prolonged response to cobimetinib, and is an example of this sort of like evolution of an LCH to an ECD phenotype. And then this patient was initially diagnosed with LCH only of the mastoid, lymph nodes and bone, very, very typical LCH manifestation, very unusual for ECD, has a BRAF fusion, and then while on cytarabine had progression, and then sort of a renewed skin assessment demonstrated these non-LCH papules on the skin, and then sort of a little fleck of a tibial lesion later. And then he has also had a lasting response to MEK inhibition. So I think that this, this represents a sort of a more clinically and molecularly diverse entity than may have been previously appreciated. There's instances of more of an LCH phenotype, not necessarily just an ECD phenotype, and sort of evolution from one to the other. I think that a lot of the take home is to the LCH oriented clinicians, because I think that, when patients with LCH sort of do not respond to LCH directed treatment, at all in the first instance, it's a good opportunity to consider whether there may be a non-LCH component of disease. And I think that when, what I've put into my practice is that when I see one of these mixed entities, if there's even the tiniest component of a non-LCH, they get a targeted treatment, and I don't waste their time with LCH directed therapy, even if the component of the non-LCH is very, very small. And that's it. Thank you.
Questions?
Yeah, thanks, Eli. One thing I noticed was striking was the number of biopsies. I think 82 in 19 people. I think we're sticking a needle in a lot of places in these patients, and regardless, I mean, you can make a case for mixed histiocytosis, or even in our ECD cohort, I think median number of biopsies, or in other experience 2 to 3. Is there any sense, more pragmatically, in our guidelines we said, oh yeah, go for a soft tissue lesion. Like, what is the highest yield? If you just look at just data rather than just our sense, to reduce the number of biopsies our patients get to get more cell. And I don't know if it's more for our pathology colleagues, but that's something that stands out in most of these, most of our retrospectives.
It's true that, the number jumped out at me on the screen just when I was looking at it today. I was like, wow, that's really, really high, and I'm not sure in these patients why it was so much. Probably I attempted upon progression for their LCH to try and get another sample. I think that may be why it's enriched in this population, that when something wasn't going right, they had an additional biopsy. In the ECD registry, I think the average number of biopsies is like 4 or 5, something like that. It's very, very high.
Yeah, I think it may be worth for us to sort of look at the data and just look, specifically where we clinch the diagnosis, and where, I mean, NGS, yes, we need to, but, we may not need to do NGS on every biopsy sample either.
Eli, thank you for your cautionary tale. I think it's generally true for mixed Erdheim-Chester and Russi-Dorfman, maybe more so in adults, that it's a more difficult disease to treat. In children, we see a lot of mixed JXG, LCH flavors in the biopsies. And in my experience, they tend to respond as well as the garden variety of LCH. So it may be true and partially related.
Oh, that's interesting. I will keep my advice to myself when it comes to kids, though, because I've heard of such cases, and I have a similar instinct, but it's interesting to know that that's more chemoresponsive in kids.
Yeah, I would echo that. And I think that is an opportunity for harmonizing the definition of what mixed histiocytosis is, because I do think that it may be worthwhile to look at your cases of the ones clinically diagnosed with separate entities or separate disease parts versus the mixed in the tissue. Because I think that when you do a large panel, you can often see this biphenotypic staining, and there should be a distinction between, can you sort of micro dissect out specific areas of interest versus having shared staining throughout the tissue. And I don't think it's clear in always the minds of the pathologist, because once you start doing a larger panel, you can see differences. And I've seen cases where there's still a small amount of CD1A and longer in an otherwise JXG, or, opposite of that. And it may have a different clinical significance than these types of cases that clearly have LCH first and then ECD. So it may be worthwhile to sort of do some sub-analysis to see if there is some type of difference in those two.
Interesting, yeah.
So Eli, you're very optimistic, and I assume you're looking at response based on the PET determined tumor burden. Would you be as optimistic in patients who have neurodegeneration?
I mean, trying to think if I've seen neurodegeneration in the mixed diseases, maybe in a couple, patients with LCH and then sort of subsequent ECD with neurodegeneration. And unfortunately, yeah, it's a difficult entity, but I think targeted therapies are kind of the best one that we have. Yeah, better than chemotherapy.
What would you say your experience has been, though? Or your gestalt, if you have one?
I would say that the modest responses with targeted therapy and then, how well they're sustained is variable. Yeah.
How often does it happen to your pathologist or to the pathologist in the room to see clearly a mixture of the two populations of LCH and ECD cells in the same biopsy? Because I think that we more often observe clinical or imaging lesions that are compatible with the two diseases, but on the biopsy, it's quite an exceptional finding. I don't know if it's my
I think
view
it's
on this.
uncommon, but I would say underappreciated, to an extent. And I think that if there's a close partnership between sort of the treating clinician and the pathologist, and you say, I'm giving you this, this happened, it was signed out as Rosai-Dorfman, but it's sitting in their right atrium. Like, do you see an ECD component because of where it is? I think that, I don't know, I think it's underappreciated. It probably could be observed more. Do you guys agree? We'll give you a microphone to agree with me. That's fine.
Yes, I completely agree with you, Eli. So I think from my experience, when I've seen mixed disease in adult patients, there's a tendency to have more tissue, a larger size of the biopsy. So it could be that if you had a larger biopsy in some patients, you might see two components. So I don't know if that's the case, but it could be. On the other hand, I think that the finding of two different phenotypes, morphology and phenotypes, is uncommon in adult patients, in my experience.
Thank you. Yeah, I thought we're caught up now. I thought I had a couple of minutes to introduce the entire history of Mayo Clinic, so I'm gonna change my mind and not do that. It's I can see that it's good to have pathologists in the room. It actually generates a very lively discussion, and I think we should invite more pathologists in the future.